So I would like to first thank you. And honestly, we are humbled and honored to have Dr. Srijon Mukherji with us here today. And he has graciously agreed to take time out of his schedule to present on the application of digital technologies in maxillofacial surgery. Dr. Srijon Mukherji has been practicing the complete spectrum of oral and maxillofacial surgery, from aesthetic facial surgery to advanced head and neck, skull-based oncosurgery, as well as craniofacial, corrective, and reconstructive surgery for the last 17 years. He has numerous international and national publications and presentations across surgical specialties on traumatology, orbital surgery, regional unusual pathologies, airway interventions, and neck surgery. He's also a leading proponent of training the general maxillofacial surgeon as a priority in India. With this idea in 2008, the Calcutta Institute of Maxillofacial Surgery, as is known as CIMS, was established as the first non-trust, non-corporate, single specialty maxillofacial hospital of Eastern India. Apart from being a regular faculty for MDS oral surgery for Rama Dental College, Kanpur, Dr. Srijon Mukherji is an invited honorary faculty for MCH plastic surgery at the prestigious Calcutta Medical College, and he's also an examiner at the Royal College of Surgeons of Edinburgh, UK. He's also a consultant at Calcutta Medical, Fortis, Kolkata and Apollo Gleneagles Hospitals. And we are very honored to have him here with us today. So without much ado, I would like to hand over to Dr. Srijon Mukherji for his presentation.
Thank you. I'll just get the screen here.
Yeah. Shomesh, can you allow? Yes, thank you.
Yeah, just so can you all? Okay. Just we are in the process of. As I'm more comfortable with the use of digital technology in surgery. Here I'm finding a minute or so of trouble to get my presentation on, which is here. Yeah, okay. I think it is going to show now. Thank you. So there it is. Can you see the first slide? Are you all there?
Yes, yes, yes.
Okay. So we are going to talk about digital technology in day-to-day oral maxillofacial surgery, as we practice at CIMS and many other areas. We are regularly into this now. I must, because this is very important for them. I think there are some postgraduate students in our panel of people who are now listening to this. For them, I need to mention that it is an important part in the last section of final year MBS. That is the present new technologies in the subject. So to take a note of this, I have covered most of the area apart from one which I do not have much of an access to, which is digital navigation. I think that will be covered by some of my other speakers today. Okay, we have moved on from the point that the CT scan became 3D. As you see, there is one which we are very used to now. Gradually, day to day, our consultation tables are going to look like this. That is actually, one day I got a few of the skulls, the 3D models on the table, and it was looking somewhat like that. And we use 3D technology in distractions of all sorts, in complex volumetric corrections of orbit primarily, extensive deformities in trauma patients, recontouring surgeries in fibroosseous lesions, and reconstruction plates are sometimes also adapted on 3D models for certain areas. I will show the examples. That is all the presentation is about. It is used for strategic aesthetic correction templates, and nowadays we are using it regularly for total joint replacements, especially in the custom joints. And the patient-specific implants is the biggest use, where directly the digital technology is going inside the patient and staying with them. Starting with the placement of intraoral maxillary distractor, that these are real pictures, how we do it before taking the patient to the operating theater. It helps greatly in the 3 points of parallelism, planning of planning of the osteotomy. As you can see, the pencil lines are drawn there for the osteotomy cuts. What happens is if you're just placing it at the time in the operating theater and bending it, rebending it, it is not only time consuming, but there are other problems. The biggest problem comes in parallelism, because parallelism is in 3 dimensions. I'll show you how it works. You see here, there are the 2 distractors placed, which you see the before and after situation, where you can actually almost see 1 cylinder, not 2. And that is how the parallelism should be. And it becomes extremely easy when we do that before we start the surgery on the 3D model. And as a result, move on to another form of distraction where we do the transport disc. Transport disc distraction, we do the full distraction on a 3D model, and we are sure where we are going to dock and how things are going to move. This is a makeshift transport distractor. We are not that rich to have the real, the best ones, so we make it ourselves. And that's the surgery. You see the distraction which you had seen exactly on the 3D model, and it goes on. This was a patient who actually was a patient of osteoradionecrosis. That's why the skin tissue is bothering over there still, but we have got a mandible. We guide for multi-directional distraction. The 3D distraction, the distractor that you see lying over there in very complex defects, it is essential for us to prepare beforehand. It is used in hemifacial microsomia, severe mandibular hyperplasias, various craniofacial syndromes, and in some post-ankylectomy cases. I'll just show one example. Hardly any, obviously you can identify the syndrome here. Hardly any mandibular ramus or condyle. Very difficult to directly go ahead with the distraction for that mandible. But it becomes very easy when you just put the osteotomy cut there and take the remaining segment to the desired area, fill the void with wax, and you get the mandible that you are targeting. And you are now ready with your distractors. You know the placements, you know the osteotomy lines, and you get your result. You get a mandible out of almost nothing. This is just immediately on the day that the distractor was removed. Next is the volumetric correction of orbits. In multiple ways, volumetric correction of orbit is a challenge, because we have to do it with, we cannot do it with complete vision. It is often done under a partial accessibility. So if we have the things done on the 3D model beforehand, makes life so much easier. It is also good for safety margin. Here you see a proptosis which was corrected, and on the lateral wall of the orbit on that side, you can see a hole which was created from beforehand, and that was the safest position to remove bone and then extraconal fat from there. So a template could be made by cutting a small aluminum piece, which template was placed at the time of surgery. That exact hole was reproduced in the lateral wall of the orbit, and the volumetric correction was achieved. If you see it is the right eye, where it is touching that line, and in the next it is behind the line, whereas the other eye has come to the same area. These are things which you are actually approaching from just one aspect. In a 3-dimensional area, you are just approaching, getting one aspect open. So it is important to have a control, and I think the 3-dimensional technology gives us the only available way, apart from also navigation at the time of surgery. This is another similar situation while handling a trauma. There is hardly a guide. If you see the CT scan on the side, hardly a guide to have the volume that we have to reproduce, because there is no piece of bone that can anatomically reduced, and it is sort of quite old. So we are not going to get what we require here. So what we did is just taken out that small piece first, taken an impression of the opposite side, and created so replicated the volume, and we prepared everything beforehand. went in, mobilized the bone pieces, just followed, used the plates as template. If the plates which were pre-bent on the model, if they were fitting nicely, that means we are in the right place and we got the volume. Recontouring surgeries for fibro-osseous lesion is often very tentative. You reduce kind of what you think is the most suitable, but that may not be the right volume. 3D technology can help us in this situation as well. You just do a mirror imaging, the mirroring of that side, which you can see in the first model. We have mirrored the side, and on the side that is to be trimmed or that is to be sculpted, we will make, I will show you what we will make. Exactly same thing has been done in the mandible for the other case. So we make this kind of templates, and these templates will actually allow us to reduce exactly as much as we reduce. There you see the bone is being reduced, and the template that we prepared, the transparent template, we place it in that area. Till it doesn't fit perfectly, we would have to trim. So when it fits perfectly, you have got a perfect replica of the other side, because this template is based on a mirror replication of the other side. Same thing happening with the bone. Here it is more of drilling, and you fit the template and you get the result. Adaptation and contouring of reconstruction plate in resection cases. Why do we need that? We can all bend the plates. Yes, it will be a little easy, but sometimes it becomes essential. This is the case of a osteomyelitis, where a part of the mandible is going to go, and due to severe COPD, we have to perform the procedure under local anesthesia. So under local anesthesia, I didn't find it suitable to fiddle around with bending and rebending. So a simple 3D model helped me by the same process. Opposite side was mirrored, and we contoured the plate according to that side. It went in no time. Here is another area, the craniosynostosis cases, where we use 3D technology extensively. You see how the 3D model in the central section, you can see the 3D model has been operated upon already, and we exactly know how much gap we are going to leave back. Otherwise, we might feel very threatened to leave that much gap, but we knew from before that that was essential. And you see the same gap is replicated just below that model, and we got that kind of a craniosynostosis corrected. There are certain times where craniosynostosis can give real challenging situations, and there we have to fiddle around with the bones a lot before we can achieve, like we can really fit the jigsaw and get a good result. So in these kind of situations, this is a failure of somewhere else, an S institution, and there was a refusion where the head was getting taller and taller, and we had our own technology of switching the calvarium, the right side for the left side, upside down. This is a technique which I use, and I developed that technique only after I had started playing with the 3D models, because I saw that it was working well. And there the procedure is going on. The bandeau is being removed and replaced. See, the bandeau is coming back. This is the head afterwards. Just to remind you, this is the head that we started from. I would have not felt very confident to do this without my access, extensive access to playing with the 3D models for all the time that I wanted before I went into the surgery. This is the child now. The next area where we are finding the use of 3D technology is in orthognathic surgery. This is not the result that you see over there, is that of a traditional splinted surgery, a biomaxillary surgery. However, there is something called splintless surgery that has come in today, which has removed these stages of models, face bite, articulation, model surgery, all that stuff has been eliminated. And the wafers, which we trusted so much, the splints for orthognathic surgery, there was nothing, no orthognathic surgery was proper without the use of splints. This is a case of a Bimax where first you see the interim and then you see the final splint. There is a new approach of splintless orthognathic surgery, and that is again a PSI. You prepare not only the final plating system, but you also prepare surgical jig so that the final plating system doesn't betray you at that time if the lines of your surgical cut were different. So this I am using a web page here just because I don't use it. I cannot afford to use it yet, but I hope I will soon. As it becomes more and more available, it will become less expensive. So that is the splint that you see. A metal splint has been fabricated, which is there just to put our cuts in the maxilla. And after that, there is a custom plate fitted, prepared in the new position of the maxilla. So that is the plate in position. If you remember, here was the cut, and there's the plate. Same thing for the mandible. That's how the template comes in. And the template is showing in the figure D. The template is showing where we are going to put the cut. We have placed the cut, straightforward BSSO cut, and then we had prefabricated plates which will go in exactly at the position required, and you get the desired result. This, at some stage, will replace our routine plaster and wax business of splint, maybe. But, well, when possible, this should be very precise. I was in a debate in the last national conference where I was against the concept of complete splintless surgery because I was calling this internal splint. So it was a trick of debate. And we did actually, it was more of a win. We didn't agree that there can be good splintless surgery. We said, yes, this is a surgery which you are calling splintless, we are calling internal splinted surgery. Now we come to the last section of the regular use of 3D technology. It's like
for preliminary design, we have
yeah. So there is a lot of discussion that goes on like this, and after which we proceed to prepare the PSIs. I will just show 4 recent cases of PSI that we performed at the institute. This was an older defect of a resected AVM, and this is how the inside was. You can actually still see some of those coils left in the vessels. So just a simple opening and getting your prefabricated PSI in place. You see the position of those implant sockets over there. Dream of an implantologist, ideal position, ideal height, everything correct, because it is all man-made, machine-made, digitally made, and we just place as many screws as you want to feel comfortable and safe. In maxilla, this works very well. In my experience, it is best for maxilla because water doesn't travel upward. So in the mandible, when we do the same thing, I am always scared that there will be trickle down of saliva with bacteria inside, all the way leading to the points where my holding screws are holding the PSI. So I avoid the mandibular PSI. All the PSIs that you will see I have done are with maxilla. So this is the PSI in position. And that's a prosthesis. The prosthesis looks old because the patient was so comfortable with her old obturator that we cut the top part and converted it into an obturator that fitted in our prosthetic design. And this eliminates huge big surgeries and complexities of free flaps. Free flaps are fantastic, no doubt about it, but sometimes you can get away and make life much easier for both yourself and the patient with this simple digital friend of ours. There's another one, and this one is from the recent time of the saga of black fungus. We had to remove the whole of maxilla, most of maxilla for this gentleman. You see, the maxilla has been removed, one side completely, and other side only the posterior aspect is still there. That's the PSI, simple PSI prepared in India in short time, after a lot of discussion though. And that's the exposure, that's the placement. As you can well appreciate that this is no big deal. It is much, but the number of people who will be happy to do a free flap over there, and the number of people who will be happy to put in this PSI on that same patient, you can easily understand the difference. And for us, more patients benefited is what we are here for. So that's the PSI being firmly secured. That's how it looks inside the mouth. And that's the OPG. That's the prosthesis. And that's the patient. Another one previously operated. There is a free flap there, but that free flap is just a soft tissue flap. And the patient wants something to support his upper left face. Here, there were so many incision lines that we could easily open it because we needed a cheek support here. So we just opened it, placed a nice framework. On the other side, the incision is for a nasolabial flap because, as many of my maxillofacial friends know, that we do get a lot of patients operated for oral cancer who do not get their oral submucous fibrosis corrected, unfortunately. And so they return with a closed mouth, which is something that should have a lot of attention and should be banned. This way, it should not happen. So anyway, here we were in a position, they actually did such a nice free flap, but not anything to open the bands on the other side. So there was a tiny mouth opening. So we had to do this at the time of placement of the PSI. This is the last one. This was a recurrent case of central giant cell granuloma, where we had to remove a lot of maxilla there. And again, PSI was our solution. Very same picture, all of them. And there it is. So it has become a very simple solution where we don't have to think much before going ahead. And it is not that expensive either at the moment. The last use that I'm doing nowadays, this is a very recent pre and post-op of a mandibular. Not this was the prosthesis that you see there and the patient that you see are not the same. The prosthesis is bilateral prosthesis because I found that I didn't have a separate picture of the prosthesis taken before the surgery. So I placed the a previous prosthesis there. This was a lady who had ankylectomy surgery done before, and we extended the mandible afterwards. So what is the special advantage of these custom condyles? We have a mirror referencing, and then we can design and redesign how we are going to get the fossa component and the condylar component. And this is a very interesting phase. This is a long phase, actually. If you are going for PSI activities who have not yet started, you should know that this phase can get pretty frustrating. You see, I was shown once this kind of a design for the side affected, because the engineer over there who was the designer, they would not know that the teeth can be put apart. So the teeth which were together was giving a very little space to them. So they very kindly didn't move the jaw at all and produce that kind of a design, which obviously had to be changed. They will also produce designs where which cannot be introduced. This was a jig. This was the jig fabricated for the case that you have seen. The jig design was like this, where there was an internal wall. And if you are actually entering that area, there is hardly a possibility for you to get that wall inside. So that is because the person who is designing this is not conversant with the anatomy of the pterygoid area. So there was this wall which I asked them to remove. That's how I asked them on the phone by drawing with my finger. And finally, this kind of a jig came. You see at the top corner, and the jig worked fantastic. Okay, this is just the market leader. This is how the best quality jaw joint, custom jaw joints look like. But we get something reasonable anyway. I will move on from this. This is not. Yes. So this is the result in that lady, the mouth opening. Obviously, the mouth looks pretty dirty because she has opened the mouth after quite a while. And that is the Indian custom joint that you can see on the side, which was the result of the discussion about which we are talking. And that kind of brings us to the end of my presentation of use of digital technology in my regular practice. And I think this covers a good chunk, but there is even more that can be done in the digital technology use in maxillofacial surgery. Thank you.
Thank you, Dr. Mukherjee, for that really enlightening talk. I would like to open the floor to discussion. Any questions that anyone might have, this would be the time to ask if you have any questions on the talk just given by Dr. Mukherjee.
You can unmute yourself and ask the question.
Yeah, actually, you see, it is such a simple thing that hardly any questions. Anybody? Because I myself, maybe I'm using it for last 5-6 years very extensively. So I believe that I can answer some of the questions, some of the complexities I've faced in it, if anyone has any doubt.
Dr. Harsh, I think you're trying to ask a question. We can't hear you. Not yet.
Cannot hear you. Please, if you just click on unmute. Yeah, probably.
Or Dr. Harsh, if you want to put your question in the chat. Actually, there is a question in the chat. Let me just read that out for everyone. There's a question from Prasad Vagadale. Hopefully I pronounced your name right. Is there any case of exposure of PSI in post-RT patients?
PSI is not the ideal solution in post-RT. When we know that a person is going to get radiation therapy, we would not recommend a metal piece to be your substitute for bone. If you know that this patient is going for radiation therapy, and if there is a need for reconstruction, especially of mandible, most of the cases would be, it is free fibula. There is no doubt about it that is the gold standard. What happens is radiation gets reflected from metal, and it is double radiation to the skin above the metal, and it is bound to get excoriated, whatever metal it is, a simple recon plate or a PSI. So it is not recommended. Long after radiation, if you are doing a secondary reconstruction, which I have done in one case that I had shown there, it is perfectly fine. The number of years that we are watching them is not too many. So till the time I have not seen excoriation due to radiation, because I'm talking about quite a few years down the line after radiation that we have placed the implant. If we are placing an implant in a patient who is now to go and get radiation, I would never do that.
Thank you, Dr. Mukherjee. There is another question from Dr. Harsh Thar. He wants to know if your experience with zygoma anchored implants post macillectomy, and whether you routinely use an issue cover over the implant.
Zygoma, I think you're talking about zygomatic implants, the dental zygomatic long implants. We routinely use zygomatic implants, and the zygomatic implants get thoroughly covered with soft tissue inside the mouth. I would normally press my, if you are using zygomatic implants, the diamond drill, the side cutting drill, I would press it all the way till the drill gets completely disappeared within the margin of the bone. So my zygomatic implants are 90% inside the bone. The little bit of the bulge which is outside is always covered by bulky amount of oral soft tissue.
I think that answered the question for Dr. Harsh. Yes. Okay, great. This presentation is being recorded, so if there is any follow-up question, we can always go back and ask the panelists for the answers. But we have about 5 more minutes for this section of the talk. If there are any more questions, we'd be happy to take them now. If I have a question, if that is okay, if there are no more questions, I'll ask one more question from my end here, Dr. Mukherjee. You obviously have been using digital technology for many years, and you're kind of one of the pioneers in Eastern India in this technology. What do you see as the challenges for using or for growing the use of digital surgical technology in the oral and maxillofacial space? What do you think are the challenges that need to be overcome over the next, let's say, next 5 years?
The biggest challenge is that this requires an infrastructure which is expensive to be created. To start this, the softwares, the biggest cost comes in the softwares, which people discount. People don't understand. Initially, I didn't understand that the cost is not that of the material or the last 3D printing. The technology that is involved in the softwares of designing, because designing, I have used the materials from different companies, so I know how big difference there can be in the output, in the final result, because of the software differences. And this will only be solved when the numbers increase. So that is an important thing, that more and more people need to get interested in this. It has to come in the more of the lectures in our postgraduate curriculum, not only for maxillofacial surgery, but for other people who work on the facial skeleton on this area. If everybody know about this, if everybody know the convenience that it can produce for us, then more people will use it, and only then will the software cost can be nullified, because that cost is taking out the chunk of the cost of what we are having to pay for this. In a country like India, cost is such a big factor, and I think that is one of the biggest deterrents. Another deterrent, which is a kind of like a negative deterrent, is that this technology, as I showed those maxillary reconstructions, this technology is kind of too simple. So there is a risk of people with extremely limited experience trying their hands on the boys' toys theory. And I have actually seen and removed very nicely made PSIs, but nicely made by the engineer, not very nicely used in the decision-making area by a very young surgeon. That I think some of you can understand what I am talking about. A surgery is not about the technical skill of actually doing the stuff. It is the decision-making and planning that goes behind it, and that is something that requires experience. There is a problem sometimes that experience is something which we do not have to depend on our own experience alone. We are in a vast society, and we should talk to people who are doing these things for some time, and that's how we have experience of 100 years by joining the 5-year, 6-year experience of 20 people. That is experience. So once we do that, then we will be safe, because now there are some PSIs being placed which probably shouldn't have been. Just exactly the discussion like before, that if you place a PSI, a fantastic PSI mandible you create before the radiation is done, you send the patient for radiation afterwards, the PSI comes out and you start screaming that PSI is not a good technology. That problem is real. So we have to think about it, and there should be a situation where there should be a marriage between the PSI and the young surgeon in some platforms. Like this one is a small one. There should be some official certified platforms where the use should be made clear by people who are using it. Because it is dangerously simple, and that can make some people tempted to use it without any experience of the actual stuff. You first do it in the traditional way, then you start applying the modern technology. That's how things develop.
Thank you, Dr. Mukherjee. That's very well said. If there are no more,
and here,
yes, please go ahead.
yeah, we are in the junctional phase, and at this phase, it has a risk of being used in a sort of an experimental way, which is not allowed to be done on human subjects. So we have to be particular about this.
Yeah. There is one more question from Dr. Mihika Bala, I believe. The question is, what are the other cases where you would try to avoid using a PSI other than the RT case you mentioned?
At present, I avoid mandibular PSI, which have got an intraoral communication. What I mean is, if I am placing a PSI for a mandible through the skin, and there is no teeth inside, and we have no plan of placing teeth, then I am happy with it. But if I am doing the ones which are presently getting popular at certain areas and then losing popularity very fast, are the ones with implants that are sticking inside the mouth, and there is a metal underneath. Those implants, in my experience, I have all, because as such, these PSIs are new. And even in this stage, we are seeing failures of those more often than the maxilla. Maxilla failures are very, very rare, whereas mandibles with a direct connection into the mouth do keep failing. And the reason, as I mentioned, I believe, is the simple thing that water travels downwards. So under gravity, water, this saliva carrying bacteria, is finding its way to go and through capillary action reach the the screw joints, and that is making them fail. So for me, at this moment, in the present technology, I would not use mandibular PSI with implants, with dental implants, I mean to say. If they're all the way completely underneath soft tissue, probably fine.
Okay, thank you so much. Thank you very much, Dr. Srijon Mukherjee.